Caroline Cox, one of the co-directors of the Resident Scholars Program, and very excited to be introducing as a whole our second-year resident class this morning, who are going to be giving our rapid-fire presentations of their planned scholarly projects that they'll be completing over the next 3 years. So these projects are in various stages, just to kind of set the stage, but they're not expected to be even at like the definite plan for the project today. And so we want your feedback, and they want your feedback. So we have only very tight time for questions after each presentation today. So we do have this QR code up here that hopefully you will take a scan of, and it will direct you to a Qualtrics survey where you can put in feedback or questions for any of the presenters so that they get even more feedback than we really have time for today. In addition, that survey will be emailed to you. So if you don't catch the QR code right at the beginning, you'll get the email too. And we really do, and they do appreciate all that feedback. And then the code to get your CME credit today is BAYMUL, Baymule. And we will just go ahead and get started with Chelsie.
Bit nervous and delirious, so forgive me. I'll be presenting on improving the induction process for expectant mothers. Dr. DeMeo is my mentor. As we all are probably familiar with the ARRIVE trial, it was a study that showed that low-risk nulliparous women who presented for induction of labor at 39 weeks or above kind of showed it didn't show a significantly higher frequency of adverse perinatal outcomes and also a lower risk of cesarean delivery compared to patients managed expectantly. Given this, the elective induction rate kind of significantly rose significantly to, in 2024, it was at a rate of 44.7%, according to the CDC. I don't think Merida Hospital has not been any exception to kind of this increase in induction of labor, whether it be elective or medical, with just over 5,000 deliveries in 2023. I know myself, as well as probably some of my co-residents, have also kind of like felt this kind of increase in inductions. But there were some observations that I myself kind of have observed, essentially, as my tenure as a PGY1 on the L&D floor, including patients not really having a lot of knowledge of the induction process, despite kind of discussing it in clinic, including like patients who had prior inductions in the past. This will often take up significant time, like counseling the patients kind of like on the interventions that we use and kind of like the overall timeline, taking away kind of like time from a busy labor floor. And so usually the floor is like the management of the floor is always like very acute. And so to take 15, 20 to 30 minutes to kind of like talk to patients about the induction process can be a significant chunk of time. So my hypothesis is by creating and providing a resource materials detailing the induction process, including interventions, timeline, and overall expectations, particularly for patients who are primes, prior to the scheduled induction, there will be an increase in patient satisfaction and understanding. My aims are to assess for knowledge gaps and understanding in the induction process for primes who are scheduled for induction at Merida Hospital. If there is a need, just based on my assessment, we will use patient responses and a pre-quality initiative to generate patient resources. Another aim is to also make the process of starting scheduled induction more efficient for all of the residents involved in these patients' care. And so the study design, it will be a plan-do study act methodology where we'll kind of refine the effectiveness of the generated resources based on multiple cycles to create a resource that is digestible for patients to kind of, in layman's terms, things that in a language that they can understand, whether that be like through a paper resource or through something electronic that can address these knowledge gaps so that when they do get to the labor floor, they're kind of well equipped with knowledge and like understanding of what's going to happen. Again, particularly for those prime patients who expect to come in and have their baby in like 5 or 6 hours, which is just not realistic for most patients, I should say. And looking at inclusion and exclusion criteria just preliminarily, wanting to kind of like keep the UW-ASOG kind of patient population as it's just easier kind of like to access those patients, particularly in clinic versus like private patients. Para zero patients scheduled for induction, although like later we could probably expand to those patients who are multiples. And patients who can ideally receive this resource at least a week prior to their scheduled induction, so they're able to kind of like review the materials and be able to digest it, so that when they come in for their induction, they are knowledgeable. Exclusion criteria, those patients who are presenting for same day induction. I think we all know that there's some patients who just pop up on the board and you're just like, wow, you're just here. Unable, and those patients who are just like unable to receive the induction resources at least a week prior, so that they're able to kind of review. And so as far as methods, we would use a pre and post quality initiative methodology. So again, UW ASOC patients who are primed, scheduled for induction, the initial step would be before kind of making the resource, kind of recruiting patients to do a survey, essentially, who have just completed the induction process, whether that be like on the postpartum floors or at their 6-week postpartum visit, and determine their experience, like what they liked, what they didn't like, what they kind of thought the process would be versus like how it was. We will use these responses to generate materials, resources, based on the patient's responses and how they, honestly, like how they would have liked to receive the material as well. And with those, so generating the resource and using that and creating that resource, disseminating it to patients, seeing how they, you know, after they have their induction, seeing how the resource like helped them. And again, like if, you know, patients have feedback, going back to the drawing board, seeing how we can again refine the resource. And so doing the post-intervention surveys to get an idea of like what the patients thought and if they found that the resource was effective. All of the survey responses will ideally be collected in REDCap, depending on like how we'll be able to get the survey to patients. And then we'll assess for variables like age, BMI, and race for the pre and post quality initiative groups. So, any questions?
Probably time for one question.
Well, I had some like thoughts and comments, but I can do a QI instead, or a QR code. Okay. 2 things. One, this is great because in the clinic side, there's also very little time. Exactly. I think we all share that. Anecdotally, I've heard that the Meritor videos, like the patients who participate in the Meritor education do get some good education on the induction process. And I've heard from patients that that's been really helpful. So it just might be a resource you want to look at so you're not reinventing the wheel when you're creating like an intervention. The other thing is survey can be really challenging, right? Patients who are newly postpartum probably don't want to be participating in the survey. You might want to look at like doing some qualitative interviews for folks who are like really motivated to share some feedback, especially if it's negative. Because you're not trying to generate like a representative sample or, you know, of this population, but just some good ideas of like the pain points. Mm-hmm. And then also looking at the, what's the survey the name of the survey that patients get? And
the Press-Ganey?
Yeah, the Press-Ganey scores, because there's free responses in those, and that might be a good way to identify patients who also had like less than positive experiences or positive experiences, just to also identify like where you want to be targeting your education.
Sounds good, thank you.
Great, and any other comments, questions, please put it in the Qualtrics survey. Thank you, Chelsea. And then
I'm also a little bit nervous and delirious during my notification, but I will try to do my best. And I'm really excited to share my residence research project regarding impact of depression and anxiety on cytokines in women with post-cystic ovarian syndrome. And this work has been conducted with the mentorship of Dr. Laura Cooney, Dr. Alex Tenney, and Andrea Virginovich. Why polycystic ovarian syndrome? It's a well-known fact that it's super common endocrine disorder. And unfortunately, it's affecting women of reproductive age. Beyond infertility and metabolic complications, PCOS carries a significant psychological burden. Multiple studies show that women with PCOS experiences higher rates of depression and anxiety. At the same time, both PCOS and mood disorders are independently linked to chronic brain inflammation. What remains underexplored is whether this inflammation could be represented like a shared biological pathway that links PCOS and depression and anxiety. It's the reason why we are doing this research. This is ongoing prospective cohort study in Generation Fertility Clinic with a data collection that began in 2018. We do have two groups. Exposure group, it's a women who are experiencing depression and anxiety, assessed via validated questionnaires. And comparison group, it's a women without depression and anxiety. It's being set with low and normal scores on validated questionnaires. Also, we would have a subgroup analysis. It will be women with polycystic ovarian syndrome and non-polycystic ovarian controls group. Our eligibility criteria, it will be women of reproductive age who are undergoing IVF treatment in a clinic with normal ovarian reserve. And exclusion criteria, technically, it will be some chronic inflammatory conditions that can cause inflammation by itself. It can be endometriosis, autoimmune disease, type 1 diabetes, malignancy, hydrosalpinx, and usage of immunomodulators. How it will be defined. Psychological symptoms will be defined using PHQ-9, GAD-7, PGY2 for depression severity. Also, we will have inflammatory panels that will include 34 different cytokines, with the most common like interleukin-6, TNF-alpha, CRP, and interleukin-1 beta. Also, we will collect samples over 2 time points. It will be plasma collection at the time of start of IVF cycle and at the day of egg retrieval. And also, we will assess follicular fluid at the time of egg retrieval. And honestly, follicular fluid assessment, it will be unique because there's a lot of different research who are assessing plasma levels, but there can be ongoing inflammation in the bodies that can influence levels of cytokines in the body. Sample and sample size. It's we will have 61 participants in total. We do have completed data set for 36 women with cytokines assay, and we do have another 25 women with plasma and follicular fluid collection. Also, cytokine analysis and data completion is still in progress. In addition to cytokines and psychological measures, our data set include comprehensive set of demographic, reproductive, metabolic, and endocrine variables. For example, it can be age, race, BMI, menstrual cycle, fertility, ovarian reserve, and assays. We structured our study around 2 aims. Aim 1 will be to determine whether androgenic steroid levels are associated with depression and anxiety, and whether this association is stronger in women with PCOS. And our hypothesis is that higher testosterone level will correlate with the more severe symptoms of depression and anxiety, particularly among women with PCOS. And aim 2 will be to assess whether pro-inflammatory cytokine level are associated with depression and anxiety in both PCOS and control groups. And our hypothesis is that women with PCOS will have, I missed the slide, will have elevated cytokines, and this elevation will be positively correlated with worse mental health scores. And our primary outcome is that a correlation of depression and anxiety scores with cytokines level in a plasma and follicular fluid. And we are also exploring whether depression and anxiety mediates a relationship between PCOS and elevated cytokines. And in a conclusion, this ongoing project aims to clarify the biological and psychological connection between PCOS, anxiety, depression, and chronic inflammation. While data analysis is still in progress, we anticipate that these findings will provide meaningful insight into how these conditions can be overlapped. Ultimately, this research lays the groundwork for future studies that could evaluate possible interventions that can target inflammation as a way to improve both reproductive and mental health outcomes in this group population. And the last but not least, I want to thank you to my amazing mentors, it's Dr. Cooney, Dr. Stanek, and Andrea Vershanovich, and amazing research team in a clinic. It's Gianna and Fernanda. Thank you for your attention, and I'm ready to take your questions. Ready. We're so impressed that.
I just have just a quick question for my own knowledge of like, what is that out there that leads you to your hypothesis? If you could just say in a short period of time.
Why are we doing that? Because there's a lot of different research, and we do know that that anxiety, depression can cause chronic inflammation, and we do also know that polycystic ovarian syndrome can cause chronic inflammation. But our main question is, if this anxiety and depression can mediate levels of cytokines markers in patients with polycystic ovarian syndrome, because there's a lot of data, but this overlap is still underexplored. It's only
so there's associations that you're trying to.
And honestly, there are also a lot of different data about serum levels, but no one did follicular fluid assessment because it should be done with egg retrieval. And we do have this chance to do it in IVF clinic. That's why.
Very good.
Oh, all right. Thank you so much. So. My project was aspirin dose and risk of postpartum hemorrhage, compared 81 milligram and 162 milligram to no aspirin. My name is Michelle DeMeo, and my research mentor was Dr. Erin Bailey. So low-dose aspirin, typically 81 milligrams, is commonly recommended for individuals at high risk for developing preeclampsia due to its ability to irreversibly inhibit cyclooxygenase 1 or COX-1 enzyme, thus reducing thromboxane 8-2 synthesis, improving placental blood flow, and decreasing inflammation. Numerous studies have confirmed its effectiveness and general safety in pregnancy with minimal risk of adverse outcomes such as postpartum hemorrhage. We know that higher doses of aspirin inhibit both COX-1 and COX-2, theoretically increasing bleeding risks. And recent studies have suggested that the higher doses of aspirin has superior protection against preeclampsia. Notably, studies have found lower rates of preeclampsia with 162 milligrams of aspirin compared to the standard dose. However, while these findings are promising, there's limited data that specifically addresses the safety profile of higher doses of aspirin, specifically regarding the rates or incidence of postpartum hemorrhage. So our study was a prospective cohort study that occurred between September of 2015 and December of 2024 at Unity Point Health Meriter Hospital. Our inclusion criteria were singleton gestations delivered at or greater than 24 weeks gestation with complete delivery records. Our exclusion criteria was multi-fetal gestation, delivery prior to 24 weeks, and cases of delayed postpartum hemorrhage defined as occurring greater than 24 hours after time of delivery. Patients were analyzed by aspirin exposure, no aspirin, 81 milligrams and 162 milligrams daily, initiated between 12 and 28 weeks gestation. Our primary outcome was incidence of postpartum hemorrhage, defined as blood loss greater than or equal to 1,000 milliliters, total blood loss. For our statistical analysis to adjust confounding variables, we performed multivariate logistic and linear regression models, adjusting for race, BMI, magnesium sulfate therapy, anticoagulation use, and to specifically look at the effect of aspirin independent of the overall changes in practice patterns. Multivariate logistic regression was used to adjust for delivery year. It's important to note that a gradual change in practice patterns due to changes in clinic as well as changes in recommendations by ACOG were observed. So we know that aspirin was not offered until 2017, and then at 2017, 81 milligrams of aspirin were initiated for high-risk patients. And then in 2021, 162 milligram aspirin was initiated for high-risk patients. Our objective to evaluate whether aspirin at 81 milligrams or 162 milligrams daily compared to no aspirin is associated with postpartum hemorrhage and total blood loss in patients receiving aspirin for preeclampsia prevention. Briefly review my results, our results from the study. So table 1 shows maternal demographics by aspirin group. You see the no aspirin 81 milligrams and 162 milligram groups. Our sample size after inclusion exclusion criteria as well as chart review was 30,941 deliveries. We see here that I highlighted some important demographics by aspirin group, and you could see that there are small changes compared, but still statistically significant. So for our demographics, our p-value was less than 0.001. So it is important to note that our results are as an effect of the large sample size. So even the smallest absolute differences in age, BMI, et cetera, will yield very low p-values, but that doesn't necessarily mean the differences are clinically important. Table 2 is our multivariate logistic regression for postpartum hemorrhage adjusted for covariates. You see the bolded values indicates a p-value of less than 0.05. I'll bring your attention to a few of our results. So adjusted odds of postpartum hemorrhage were significantly lower in aspirin groups compared to no aspirin. In the 81 milligram versus the no aspirin group for all deliveries and vaginal deliveries, it was statistically significant. This effect was also seen with 162 milligrams versus the no aspirin group. But again, this effect was limited to vaginal delivery. So we did not see this effect with cesarean or operative vaginal deliveries. Both aspirin groups versus the no aspirin group were associated with approximately 53% lower odds of postpartum hemorrhage.
And with regards to our secondary outcome, we did see a similar pattern where the total blood loss was less for our aspirin groups for vaginal deliveries, and again, was not extended to cesarean vaginal deliveries. So some brief conclusions. In summary, aspirin use was associated with reduced postpartum hemorrhage and lower total blood loss among vaginal deliveries. Our theory is that aspirin's anti-inflammatory effects may mitigate bleeding risk during labor where inflammation plays a greater role. More specifically, aspirin may modulate the labor-related inflammatory pathways that influence uterine tone and bleeding. This protective effect, as we saw, did not extend to cesarean deliveries where surgical and technical factors may predominate, with some certain surgical factors that we considered include hysterotomy, vascular disruption of the placental bed, increased tissue trauma, iatrogenic surgical contributors. Our findings invite further explorations into aspirin's effect, specifically on the inflammatory cascades in pregnancies. And RCT's power for bleeding outcomes, not just preeclampsia prevention, are needed, specifically comparing 162 milligrams of aspirin versus 81 milligrams of aspirin. Ultimately, understanding how aspirin influences both hypertensive disease prevention as well as bleeding risks has the potential to refine clinical guidelines and optimize outcomes for pregnant patients. Take questions.
What's next?
Great question. So I think ultimately this result was surprising to us. We didn't expect to see such a protective effect. Yes. So I think investigating, specifically looking at 81 versus 162 would be interesting. Investigating how aspirin really can modulate those inflammatory influences of pregnancy and labor specifically. I'm curious as to how or why the effects didn't, if we're thinking that aspirin's anti-inflammatory effects play a big role here, why it didn't. Also, we didn't see that protective effect in operative vaginal delivery since that is laboring as well. So just some thoughts there, but.
Great work, Michelle. I'm curious if you thought about, we send placentas all the time. Maybe they could look at, I don't know a lot about this, but it seems like seeing if there are differences in the placenta for people that take aspirin and don't, because when we get those placenta, they always comment about inflammation of some kind. That would just be interesting to see if the placentas of those that take aspirin and those don't are different.
Yeah, absolutely.
We'll have to keep moving, but please use the survey and Michelle will get your feedback. And we'll move on to Taylor.
Yes. My project is in the medical education realm and is titled From Text to Immersion, a randomized controlled trial assessing the impact of virtual reality-based learning game versus traditional text-based study on understanding the steroid synthesis pathway. And my mentor is Dr. Bhagavat. So there has been, in the last several years, increased popularity of virtual reality use, not only in gaming and in popular culture, but also for use in education and specifically in medical education. Benefits have been shown for the use of VR in medical education and surgical training, clinical simulation, and learning anatomy. Nearly half of the published studies that looked into the use of VR in med ed focused on this use specifically in minimally invasive surgical techniques. So the graph shown here is probably hard to see, but kind of shows the disciplines that are using VR in medical education, and that highest bar is minimally invasive surgery, followed by general surgery and internal medicine, orthopedic surgery, and so on. There's a big emphasis on using VR for developing psychomotor skill development, but there's a gap of the use for VR in cognitive learning and knowledge retention, and specifically a lack of this use in basic science education, physiology, and biochemistry. So we know that virtual reality enhances student engagement and learning outcomes. And we all probably remember that biochemistry is a subject with really complex molecular interactions and pathways. including the steroid hormone synthesis pathway, which is a really clinically relevant biochemical pathway that we've all had to memorize at some point in our careers. Aberrations of this pathway lead to clinically relevant conditions such as congenital adrenal hyperplasia and disorders of sex development. And so we aim to investigate the role of immersive virtual reality compared to text-based learning methods in learning this complex pathway. So this led us to our hypothesis that biomedical trainees using a virtual reality-based learning game will show greater improvement in post-test scores and retention at 4 weeks compared to those that are using traditional text-based study methods. This is in the medical education world, kind of the educational theories that are underlying this work, or the cognitive load theory that states that learning is affected by kind of just the volume and the amount of mental effort that's required to process the information. As well as the experiential learning theory, which explains learning as an experience and a cycle of like a concrete experience interacting with something, and then the process of like conceptualizing and actively retaining the information. So for our study design, we have this set up as a randomized controlled trial using blocked randomization. As some background, Dr. Bhagavath previously helped develop this virtual reality game for learning the steroid hormone synthesis pathway. And there was a previous kind of pilot study that looked at using not a virtual reality, but a computer-based game compared to the text-based methods that showed greater retention and greater scores and subjective experience using the computer game. So we have blocked randomization, including undergraduate and graduate students who are enrolled in a biochemistry course, medical students, residents, and fellows, who will be assigned to either playing the virtual reality game or completing traditional study methods. So all of our participants will take a pre-test, which is 10 multiple choice questions, and then they'll participate in the assigned intervention in a proctored in-person setting of either playing the game or reading a text-based chapter. And then all of the trainees will take a post-test with the same multiple choice questions, as well as a survey that will kind of get more into the subjective user experience. And then all of the participants will also be sent a post-test in 4 weeks with 10 new multiple choice questions to assess long-term knowledge retention. At this point, we have obtained IRB approval for the project and are in the very final steps of developing our REDCap database for randomizing participants and collecting the data. And so we hope to begin enrolling participants very soon. And thank you to all of our study team. We have some great medical students that have been really helpful. And our mentors, Dr. Bhagavath, Dr. Kaljos, have been helpful with the medical education side of things, and Jaya, the REI fellow. Happy to answer any questions.
Cool. How are you gonna recruit people? Like it's a wide swath,
Yeah.
and then how are you gonna get them to stay in the program?
We are going to send out emails. So we're working on identifying like lists of undergraduate and graduate professors who may be able to advertise their courses. Our medical students are going to help get the medical students involved. We're just going to cold call a lot of people to try to recruit. And then we have kind of an automated system throughout REDCap to send reminders and kind of get people enrolled and like hopefully retain their participation.
And you're gonna do residents and fellows across departments? across
Yeah,
the-
we were gonna target more specifically the REI department is, of course, OBGYN, potentially internal medicine, endocrinology, potentially peds, just like the specialties that might be most relevant to kind of the clinical application.
Thank you.
Today I'm going to be speaking about my project Between Bodies and Ballots, Transit Oophorectomy at the Time of Gender Affirming Hysterectomy, before and after the 2024 election. My mentor is Dr. Laura Hanks. So gender affirming hysterectomy, as we know, is a common procedure for transgender and non-binary individuals who are pursuing surgical transition. And their, clinical decisions regarding whether to perform concurrent oophorectomy are really complex, and they include things like reproductive goals, long-term hormone needs, and cancer risk. And in this population in particular, additionally, things like alleviation of gender dysphoria, elimination of menstruation, reduction of future gynecologic care needs, as well as simplification of hormone therapy management. Recent analyses have identified individual level predictors of concurrent oophorectomy, namely things like male identity and testosterone use. But we were curious about the impact of broader external factors, here focusing on the result of the 2024 presidential election as a key inflection point in transgender health care policy and rhetoric that might result in a measurable shift in clinical practice. For our study design, this is a retrospective cohort study, population being transgender and non-binary individuals who are undergoing gender affirming hysterectomy at Meriter Hospital, timeframe, a year prior to and a year following the election, the exposure, of course, the election, and comparison group being cisgender patients undergoing HIST for benign indications. Our primary outcome will be looking at the rate of concurrent bilateral oophorectomy or unilateral if they'd had a prior unilateral oophorectomy on the contralateral side, essentially end result being 0 ovaries. And secondary outcomes are the within group and between group differences in these rates before and after the election. We do have a number of covariates, so age, gender identity, BMI, hormone therapy use, mastectomy status, and route of surgery. We currently have 27 gender affirming HISTs in the year preceding the election and 40 thus far in the year following. And cisgender benign HISTs, obviously much higher in the realm of around 500 each year to 600. Aims for this study are firstly to determine whether the rate of concurrent oophorectomy at the time of gender affirming HIST changed after the 2024 election. And secondly, to compare changes in rates over that time period between cisgender and gender affirming hysterectomy patients. We hypothesized that in the year after the 2024 presidential election compared to the year prior, the rate of oophorectomy at the time of gender affirming hysterectomy will decrease relative to cisgender patients, potentially reflecting patient and provider concern regarding availability of hormone therapy, as well as increasing barriers to gender affirming care. Here's just, an overview of our methods for identification. Really, patients are going to be identified using ICD-10 and CPT codes. We have gotten a lot of assistance from Jana Lind, who's one of our clinical informatics nurse specialists here at Meriter Hospital. Inclusion criteria for our experimental group, the gender affirming hysterectomy cohort, is just gender affirming hysterectomy. And then for the comparison group, benign indication, exclusion criteria being hysterectomy for malignancy or cancer risk reduction, as well as any kind of incomplete record. Data collection will be done via manual data extraction into REDCap, which is where we're currently at. Our IRB just went through. This is our data collection tool, kept things fairly simple. You can see here some of our covariates as well as indication listed on the site. As far as analysis, we're very thankful for the assistance of Natalia and Dr. Godecker. We'll be focusing on descriptive statistics for the demographic and clinical characteristics, as well as difference in differences analyses to estimate the effect size of the election on oophorectomy rates. We are inherently limited with regard to sample size and would not be surprised if this study is underpowered. Thus, kind of pending our initial analyses, we'll consider extending our time period. That's it.
Policy doesn't actually change until the inauguration, sometimes. So maybe you do a thing about ultimate time points, which may actually get at your hypothesis of the policy actually driving change.
Yeah.
Whereas the November timeframe is the concern over policy changes opposed to policy.
Yes, that is a great point. I think kind of alongside that, we've considered that surgical planning often occurs months in advance for patients and counseling months in advance. And so it may be worthwhile to kind of block times also, like look at 3 months chunks of time to assess, but I do think that inevitably we will be extending our time points and adjusting. Dr. Adler.
I think in general, extending the time points is useful anyway when you're trying to show because when you look just at like a 6-month pre-post or a 1-year pre-post, it's harder to kind of tell your story. The other thing is you want to make sure you're looking at other confounders kind of that could push things in either direction. So like coverage, insurance coverage changes proceeding that could have, elevated the incidence of these surgeries happening prior to the election. But that's also another argument for extending your timeline on either side too.
Okay, thank you. And we have 2 more presentations to hear. So Jess can come up next.
So my project is evaluating electronic nicotine delivery systems, or ENDS, use prevalence in pregnant patients in resident continuity clinic. My mentor is Dr. Sharp. So electronic nicotine delivery systems, or as I mentioned, ENDS, have become increasingly popular with young adults and adolescents in the last decade. It was initially introduced as a cessation modality for tobacco use, but has recently become really popular for recreational use. In this presentation, I'll use that term interchangeably with e-cigarettes and vaping. So we have also done limited studies on prenatal vaping, although there's very limited data that's shown that there's a 53% higher odds of adverse maternal and neonatal outcomes, including decreased breastfeeding, low birth weight, preterm birth, and being small for gestational age. One study also did a survey among providers that showed that there was a mixed knowledge and attitudes of providers surrounding vaping, nicotine and carcinogen content, and then use in smoking cessation. Many providers on the survey had indicated that they don't feel comfortable discussing vaping in clinic and don't know much about it. And about 70% on this survey had indicated that they would recommend vaping for tobacco cessation. We have also identified that there's barriers to how this information is presented to providers. So for example, in EPIC, there's that social determinants of health section on the left-hand side. But if you only use vapes and you don't use any tobacco, that section won't show up as medium or high risk. It'll show up as low risk, even if someone has been vaping for a long time. So for our project, we will utilize a PDSA cycle. Our project focuses again on the residency continuity clinic population and in our pregnant population in particular. And our interventions aim to improve the workflow, mostly surrounding the new OB visit and the initial intake process, as well as general documentation processes in the EHR. So our overall goals are to quantify the number of pregnant patients in RCC that use ENDS, as well as assess and understand how often they vape and how much. Educate patients and providers on the significance and possible complications related to ENDS use, and then connect patients with interventions such as first breath for nicotine cessation. Our population of focus is about 30 to 50 patients at one time. And our general process, initially, when patients are called for their initial intake at this point, they are just asked about cigarette use and tobacco use, and they don't specifically delineate using e-cigarettes or vapes, which can sometimes be difficult to identify the patients that use vapes because multiple studies and different resources, including ACOG, recognize that there are patients who use vapes but don't recognize it as cigarette or tobacco use, and they may screen negative for that unless you ask specifically. So our initial questionnaire will have an additional question that just adds in, do you use electronic cigarettes or vapes? And then they would screen positive for that. Afterwards, we will put in a note in the pink sticky note that all the providers use to kind of communicate in RCC to identify that that patient will require further screening at their new OB visit. So this just kind of talks about what we already discussed. After they screen positive and we see them in the new OB visit, we will fill out the e-cigarette or vaping use section in the social history. But we have also found that even if you fill out this section, it doesn't always show up if you search for a patient that uses vaping, or if you use a program like Slicer Dicer to kind of sort through data in the EHR. So when the patient initially presents for their new OB visit, we then give them a vaping worksheet, which is
we are currently in development of making our own, but we are using a template from UNC Chapel Hill, which kind of goes through what kinds of vapes they use, how much they use, and then further gives them a reference of about how much that would be in cigarettes. Afterwards, clinicians will be able to discuss nicotine and tobacco use cessation strategies and then connect them to the resources, like I mentioned, with First Breath, which also will see people for that only use vapes and don't use cigarettes. And then we also are hoping to educate providers about ENDS use, so that way they are able to feel more empowered when counseling patients about cessation and risks related to it. That part is still in development about exactly how we will accomplish that. So this is the copy of the worksheet that UNC Chapel Hill uses. So our hope is to kind of do a similar visual representation of the different types of vapes and then how often they use per week. And then this section on the right kind of goes over the equivalent number of cigarette packs for how many vapes that they use. The initial worksheet was developed specifically for an adolescent population. So our hope is to kind of make it more condensed and appropriate for pregnancy as well. This is my bibliography, and then I will take any questions.
I just want to say, I think this is a great topic. We were actually talking in clinic the other day about how we just don't even have great guidelines for vaping and like antenatal testing and growth ultrasounds and I think it's something a lot of us are less familiar with. So I think this is an awesome topic.
Great, thank you. And then Emily.
Hello, my name is Emily. The title of my presentation is Compounding Vulnerability, the Use of Stigmatizing Language in the Medical Records for Pregnant Patients with Substance Use Disorders. My mentor is Dr. Jacqueline Adams. Pregnant patients with substance use disorders comprise a growing population in the United States, with a growth of 4 to 6% annually over the years of 2010 to 2018. Opioid use disorder, which is one of the most common types of substance use disorders in pregnancy, the population is more than quadrupled from the late 1990s to 2014, and also comprises a good portion of maternal deaths from overdose. Though pregnancy is identified as a potentially effective entry point for substance use disorder treatment, studies demonstrate significant healthcare provider bias towards these patients, which ultimately impacts their care. Over the past 5 years, a growing body of literature has used artificial intelligence to more thoroughly examine the medical record for evidence of biased and stigmatizing language, particularly among minority and marginalized patient populations. To date, this process has not been utilized for pregnant patients yet, nor those specifically with substance use disorders. For this project, we plan to utilize natural language processing to investigate provider bias in the medical record of pregnant patients with substance use disorders. Natural language processing is a type of artificial intelligence and machine-based learning that enables computers to understand, interpret, and generate human language. There are many different types of natural language processing, or NLP. The type that we're particularly interested in is something called thematic analysis, where essentially we teach this software to interpret medical charts and be able to distinguish positive versus negative themes, negative being biased and stigmatizing language. Now, it's important to acknowledge here that Dr. Adams and I are not experts in this particular type of intelligence, but we are the folks with clinical interests and clinical expertise. So we are working with a broader study team, among whom includes Dr. Ryan McAdams from neonatology, who has expertise in artificial intelligence, Dr. Tiffany Green from Population Health Sciences and Core, who's an expert in clinical care biases and health disparities research. And then we're in process right now of finalizing an agreement with a member of the Biostatistics and Medical Informatics Department with expertise specifically in natural language processing and large language models. Our specific aim is to compare the type and frequency of stigmatizing and positive themes in the medical records of pregnant patients with substance use disorders relative to pregnant patients without substance use disorders. And we hypothesize that we'll see more frequent use of stigmatizing and biased language in the charts of those with substance use disorders and less positive themes. This is a general overview of our methods, which is largely divided into 2 phases. Those phases are distinguished based on where we're getting our data from, so which charts we're pulling information from. For phase 1, we'll be looking specifically at outpatient documentation from the UW Health EPIC, using essentially working with clinical research data services or CRDS to obtain the records. We'll be looking at 2017 to 2025. And then at first collecting just kind of generalized data, patient demographics such as age, provider type, morbidity, parity, et cetera. We plan to exclude patients with a history of chronic pain because we fear this will confound our results. Key portions of the documentation, including subjective, physical exam, assessment, and plan will be extracted. And then that data will be stored in something called Platform X, which is a HIPAA compliant secure server governed by data sharing agreements between joint research commissions between the medical school and UW Health. Once we have them in Platform X, then we'll be able to undergo the natural language processing process. This data agreement with Platform X already exists with UW Health, which is why we're starting there first. Ultimately, we would like to do this on Meritor-based charts, which would include triage visits, labor and delivery notes, and postpartum notes. That data agreement is in process, so not finalized quite yet. Ultimately, we would like to compare clinical outcomes for both pregnant patients and neonates in the setting of this NLP study. This is my bibliography, and I'm happy to take any questions.
I'm sorry, I may have missed it. Large language models to study bias or stigma, has that been done in other fields? Like, does it precedent exist?
Yeah, so over the past 5 years, more of these studies have been coming out. Looking at bias, like there's multiple papers on race in JAMA, like over the past 3 years specifically. None of them have been used in pregnant populations. So we're hoping to kind of use that model in a new population.
A great project and ambitious, and the data use agreement between Unity Point Meritor
Yes.
and SMPH is not just in process, it is really, really close.
Amazing.
It's really, really close. Like, so Dr. Hoppy and I have been on this for 18 months. And we are hoping, we are like days to weeks away. So I just, as you construct this whole thing, the whole goal of that data use agreement is to make sure that we can get pregnant patient data from Unity Point Meritor Hospital over to Platform X so that pregnant patients in the UW Health system and universe actually are represented in Platform X, which is the HIPAA compliant de-identified database that the SMPH is really putting together for research across the health system, across the departments. So this getting UPH Meritor's de-identified data in Platform X will be transformative for our research platform in the department.
Thank you. Big congratulations to all of our second-year residents for getting. And we can all stay tuned for 2 years from now when we're going to hear their final presentations. And I'm sure that will be very exciting. Again, please check your email for the link to the Qualtrics survey.
No, you keep going to the next thing I have to say.
Great. Link to the Qualtrics survey for any other questions, comments, feedback to make their projects even stronger. A lot of them, as you saw, are still in the development stage. So anything is appreciated to make the project stronger. We love everyone's ideas. And thanks for coming today. And
there you go. Okay, cool. I have a quick announcement, which is that the DEI committee is in classroom 4. And many thanks to Dr. Cox for taking over the resident research program, along with Amy Godector, who has not been mentioned, and that data core in the department is huge. These are really great projects. It takes a team, and so thanks to all the faculty mentors, and great job. So thanks, everybody.